Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. Worldwide, shock is a leading cause of morbidity and mortality. It is defined as a state of acute energy failure due to inadequate glucose substrate delivery, oxygen delivery, or mitochondrial failure at the cellular level. The clinical state of shock is diagnosed on the basis of vital signs, physical examination, and laboratory data. Death may occur rapidly due to acute shock or from the consequences of organ ischemia and reperfusion injury. In shock, there is inadequate tissue perfusion or tissue ischemia, leading to compromise in normal cellular respiration. Due to insufficient delivery of oxygen and glucose, the asphyxiated cells switch from aerobic to anaerobic metabolism. If perfusion is not restored in time, cell death occurs. Therefore, every healthcare provider should understand the pathophysiology, diagnosis, and priorities in management of shock. Shock can develop during conditions of impaired oxygen delivery or impaired oxygen utilization or increased oxygen consumption. In practice, shock is most commonly caused by impaired oxygen delivery due to circulatory failure. When tissues do not receive sufficient oxygen through circulation, they switch from aerobic to anaerobic metabolism. They release lactic acid, not carbon dioxide, as they do in aerobic respiration, and there is much less ATP generation. The accumulation of lactic acid in the blood results in systemic metabolic acidosis. As glucose within cells is further exhausted, anaerobic respiration stops and ATP generation ceases. There is failure of sodium-potassium pump in the cell membrane and intracellular organelles because it is an ATP-dependent ion pumping system. Inadequate oxygen supply and decreased ATP production impair the cell's ability to maintain osmotic, ionic, and intracellular pH homeostasis. There is influx of calcium into cells leading to activation of calcium-dependent phospholipases and proteases, causing cellular swelling and death. In addition, intracellular lysosomes release autodigestive enzymes and cell lysis occurs, leading to release of potassium and other intracellular contents into the bloodstream. These activate inflammatory cascades and alter the microvascular circulation. As tissue ischemia progresses, there is activation of the immune and coagulation systems. The cellular hypoxia activates humoral elements like complement, neutrophils, and results in microvascular thrombi formation. There is activation of complement and prime neutrophils followed by oxygen-free radical generation and cytokine release. Prime neutrophils are more effective at phagocytosis, releasing reactive oxygen species and activating other immune responses like neutrophil extracellular traps (NETs). This cascade of hypoxic events cause injury to the capillary endothelial cells, further activating the immune and coagulation systems. This damaged endothelium becomes leaky and intravascular fluid leaks out, causing tissue edema and worsens the cellular hypoxia. In circulatory failure due to shock, systemic preload and afterload decrease. As a compensatory baroreceptor response, there is increased sympathetic activity and release of catecholamines into the circulation, leading to arteriolar vasoconstriction, resulting in redistribution of blood flow from the skin, skeletal muscles, kidneys, and splanchnic viscera. An increase in heart rate and contractility that increases cardiac output, and constriction of venous capacitance vessels which augments venous return. The case is somewhat different in septic shock that we shall discuss later. In shock, the reduced blood flow can lead to various respiratory events, including rapid and shallow breathing, difficulty in breathing, and potentially respiratory failure. These events are often a result of increased sympathetic nervous system activity and metabolic acidosis, which stimulate the respiratory center to increase breathing rate. Reduced oxygen delivery to the lungs due to low blood volume or impaired circulation can also lead to rapid breathing. Fluid buildup in the lungs or pulmonary edema can impair gas exchange and cause shortness of breath. Reduced blood flow to the lungs can cause impaired gas exchange and lead to respiratory failure. Rapid shallow breathing can be a sign of increased respiratory rate and difficulty getting enough oxygen. A bluish discoloration of the skin and mucous membranes can be a sign of low oxygen levels. In shock, the kidneys can be significantly affected, leading to various renal events. These include cellular injury, reduced concentrating ability, and even acute tubular necrosis. The kidney's response to shock can manifest as a range of clinical presentations, from mild dysfunction to severe renal failure, and can be influenced by factors like hypoperfusion, reduced oxygen delivery, and cellular stress. Shock reduces blood flow to the kidneys, leading to decreased perfusion pressure in the kidney, reduced glomerular filtration rate, and a decreased urine output. The renin-angiotensin-aldosterone axis is also stimulated, causing further vasoconstriction and increased sodium and water retention by the kidneys. There are excessive calcium levels within cells and activation of phospholipases as well as oxygen-free radical formation, leading to cellular injury and dysfunction. In severe cases, the kidneys can suffer extensive damage, leading to acute cortical necrosis and ultimately acute kidney injury and renal failure. This acute kidney injury can range from mild impairment to severe renal failure with varying degrees of fluid retention, electrolyte imbalance, and waste product accumulation. During shock, the body initiates a series of hormonal changes to maintain homeostasis. Key endocrine events include increased secretion of glucocorticoids, catecholamines, and vasopressin. These events are initiated by the hypothalamus and pituitary gland in response to decreased preload, leading to vasoconstriction and resorption of water in the renal collecting system. Cortisol released from the adrenal cortex contributes to sodium and water resorption and sensitizes cells to catecholamines. Vasopressin or antidiuretic hormone regulates blood volume and blood pressure by increasing water retention in the kidneys and tries to maintain adequate blood volume during shock. Catecholamines like norepinephrine and epinephrine increase heart rate, blood pressure, and blood flow to vital organs. The septic shock is a subtype of distributive shock. Distributive shock is an umbrella term for shock states characterized by widespread vasodilatation and maldistribution of blood flow. This category includes septic shock, anaphylactic shock, neurogenic shock, and shock due to adrenal insufficiency. Septic shock occurs as a result of an overwhelming infection that triggers a systemic inflammatory response. In this setting, inflammatory mediators such as cytokines and nitric oxide cause pronounced peripheral vasodilatation, increased capillary permeability, and eventually impaired tissue perfusion, even in the presence of a hyperdynamic circulation. Therefore, while all cases of septic shock are a form of distributive shock, but not all distributive shocks are septic. Other causes of distributive shock may have different triggers and some distinct pathophysiologic mechanisms despite similar hemodynamic patterns. In septic shock, cardiac output is increased and peripheral vascular resistance is decreased. While in other forms of shock, cardiac output is typically decreased and peripheral resistance is increased. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.